Hello. My disclaimer is that the views and statements expressed by me are provided for informational purposes and do not necessarily reflect those of my company, Medivo, nor the Alliance for Continuing Medical Education, nor their representatives. Okay. So my name is Destry Sulkes. I'm a physician and a co-founder of Medivo Incorporated, and I'm also a volunteer board director and the treasurer-elect of the nonprofit 501c3 Alliance for Continuing Medical Education. I'm here to discuss the LDT issues surrounding direct-to-consumer, DTC, healthcare practices, and specifically how they relate to genetic lab testing and physician oversight. My statements are based on my daily interactions with healthcare providers and with patients as a physician and as a principal of Medivo. Since 2001, our company has provided virtual healthcare services when and where they're needed, and one such service is providing independent physician oversight for a variety of organizations that receive lab test requests from individuals online. This oversight is conducted safely and securely by our nationwide network of credentialed physicians on the telephone via telephonic access and over an online platform. In addition, as a result of the rapid growth of the laboratory-developed tests in genetic lab testing over the past few years, we rely on publicly funded medical education programs from the CDC and NIH to identify and increase the genetics communications competencies for our physicians. I'd like to provide some clarity on terms that have been used widely and we think, unfortunately, interchangeably in this industry. The term direct-to-consumer itself was used in 1997 by the FDA to describe a method of advertising that provides valuable product information and increases consumer awareness, and not for consumers to bypass their physician and directly obtain a prescription medication. In contrast, the term direct access testing describes a different process where some states have allowed individuals to order a limited set of the safest and most well-established lab tests without a request, nor the requirement for a physician's order. The equivalent term in the pharmaceutical industry is over-the-counter, or OTC, where a consumer can in fact directly purchase a drug in a retail setting with no physician oversight. The confusion has arisen where DTC, when used to describe genetic lab testing, has come to mean that individuals may order their own tests, despite the fact that this category of lab tests are still largely in a research stage of development, with the most challenging results to understand. Interpretation of the reports is difficult, even for physicians with knowledge of the patient's full history and health context. And given the breadth of the associations under study, research on their overall impact on health outcomes is inconclusive. So, this is why we maintain that physician oversight is essential to safe and effective communication of genetic lab test results. While the genetic testing industry has well-established protocols and standards mentioned here earlier today and yesterday for genetic testing results as developed by the medical genetics subspecialty of internal medicine, they focus largely on inborn errors of metabolism, hemoglobinopathies, chromosome abnormalities, and neural tube defects, and of course a handful of drug response tests. But of course, the majority of the new LDTs lack such standards. So given the variability in the categories of genetic tests, the present proliferation of organizations who offer these tests, the significant challenges to the test interpretation, and ultimate uncertainty around the impact of the test results on patient health, independent physician oversight is instrumental and vitally important to protect public safety. I want to share the impact of what we're talking about today from the view of a family physician colleague. One of her patients, a 25-year-old woman, got her genome tested for her birthday. Her intent was to use the information mainly for entertainment, to share with her girlfriends, but also to see if she had any risks for inherited disorders that she could pass on to her children. Her results come back, and luckily she has low genetic risks for many illnesses, but she did have a high risk for venous thromboembolism. This scared her. She was immediately thinking, should she stop taking some medications? Should she start taking something prophylactically? So she called her doctor. Her doctor immediately did what doctors do, immediately reviewing family medical histories, hearing that she's recently taken 2 cross-country flights with no ill effects, considered it all and counseled her that she was most likely in no immediate risk and probably did not need to be on the medication immediately. But with the new risk information, she'd be sure to include that in her future ongoing care. So in summary, these genetic tests and LDTs have the potential to deliver tremendous healthcare value over time, and continued access to them is an important goal. With the help of everyone here, we can create a solution that maintains and broadens the benefits to all of us and our families in the future. I'd like to extend my thanks to the FDA for allowing me this time to present these views on this important topic.